which are which you can watch on our YouTube channel RVPGA. Today we have such a distinguished group of medical professionals, academicians, clinicians, PG, PhD scholars, and UG students from various corners of India joining us today for this webinar. So once again, I welcome you all on behalf of RVPGA. Myself, Dr. Darshana Ubhade. I'm an assistant professor in the Department of Rog Nidan and Vikruti Vignan in Tilak Ayurved Mahavidyalaya, Pune, and I will be your session coordinator for this webinar. I am honored to welcome our today's distinguished speaker, Dr. Nilay Nimbarkar, sir, a renowned radiologist, for today's webinar. This webinar is conducted by RVPGA, that is Rog Nidan Vikruti Vignan PG Association, and it is approved by Maharashtra Council of Indian Medicines, Mumbai. Before we dive in further, I would like to introduce in brief about RVPGA. So our organization, RVPGA, was formed in the year 2016 under the able and dynamic leadership of respected Dr. Subhash Wage sir, with the aim to give the legal status of pathologist and radiologist to the PGs of Rog Nidan. Our organization is duly registered under the Societies Act of 1860 at Charity Commissioner Office, Nagpur. Postgraduate students, PG scholars, teachers of Rog Nidan and Vikruti Vigyan and Chaya Vikruti Vigyan can become our members. Now we are extended our membership to the other wings of Ayurveda like Shalya, Shalakya, Kaya Chikitsa, etc. Our is the only organization which is fighting for the lawful rights of Rog Nidan and Vikruti Vigyan PGs. Even the NCISM also directed the state of Maharashtra to consider RVPGA as the stakeholder in the constitution of pathology regulatory body of the state, and RVPGA is pursuing this matter with state and central government constituently. All the communications and details regarding our organization are uploaded on our website www.rvpganagpur.com. RVPGA conducts different activities throughout the year, like a regular conduction of online webinars and offline seminars, both on national and international platforms. So far now, we have conducted 37 national webinars on different diagnostic topics, 4 national workshops, and 3 national conferences. On 14th of September 2025, we are organizing one more national conference on MRI diagnosis, Diagnocon 2025. So I will request all to join that conference. RVPG also conducting the hands-on training programs of PGs at our 35 plus partnered NABL accredited pathology laboratory across the Maharashtra. We have the publication of research papers of Nidan students and faculties in our peer-reviewed International Journal of Diagnostics and Research. Our journal is enlisted at in 8 databases. 8 issues have been published, and our current issue had a record number of 22 articles published just within 2 years of commencement of our journal. Interested students and teachers, faculty can visit our journal website www.ijdrindia.com. We also have the edited book volume series through our international publication RIPI, which is registered in Government of India's ISBN portal. Those who want to contribute book chapters, they can visit RIPI website www.rvpga.iip.com. This all information is also available on our main website www.rvpgnagpur.com. We have our YouTube channel and Facebook page, Instagram page, where you can see our educational activities which were in past and also live and upcoming events. To update our colleagues and students with recent updates, we have launched 3 diploma courses like DAPT, DXDT, DECM, and similarly, we have launched 8 certificate courses. Details you will get on our website. We have our e-news bulletins as well, which is biannually published, highlighting the achievements of our members. So now here's the time to introduce our today's guest speaker, Dr. Nilay Nimbarkar, sir. He's MBBS, DNB, DMRD. He's the director of Precision Scan and Research Center at Nagpur. He's an associate professor in the Department of Radiology at Datta Mege Medical College, Wanadongri, Nagpur. In academics, Dr. Nilay sir is a PG diploma teachers for DMRE students and at Precision Scan. He has clinical experience as CT and MRI consultant since 2006. He is a director and head of the Institute for DMRE courses in Precision Scan. Sir has 5 publications in national and international journals, 5 textbook chapters, and faculty resource persons at multiple conferences. Area of interest are adult and pediatric cardiac imaging, CT angiography, body imaging, CT guided procedures, etc. So I again welcome you, sir, and I'll request to continue to start your today's lecture. Thank you, sir.
Good morning, all. Thank you for the nice introduction, and I'm really grateful, uh, Dr. Vakhe, Dr. Hemant sir, Dr. Darshana madam, for inviting me to deliver this lecture. Last year also we had similar session in the same similar platform, and there we discussed something about CT coronary angiography. Unfortunately, I could not be online because of some prior commitments, but today I'm online and we will be delivering lecture online, and I will be available for any questions to be discussed after the lecture. I'm sharing my screen. If you have any issues, please let me know. So can you see my presentation?
Yes, sir.
I'm just sliding. The slides are moving.
Yes, yes.
Sure. So today we will be talking about CT coronary angiography, and it's one of the most demanding procedures in CT angiography because one thing, the patients are special. The machine needs to be special because the machine needs to be very robust to do CT coronary angiography, and then we have to look for many parameters before doing CT coronary angiography for a patient to be taken for angiography study. So why it is special for patients? Because patient usually, once you ask them to go ahead for CT angiography of heart, usually patients become anxious. One, it can be patient can be nagging that he predominantly thinks that he doesn't have anything in the coronaries, and why anybody is asking him to go ahead with coronary angiography. He may not be cooperative, but he may be cooperative. So different kinds of patient can be there for CT angiography. The machine for that angiography has to be 64 slice plus. So this is a prerequisite for all the CT coronary angiography, that the machine has to be more than 64 slice CT scanner. Usually patients used to do, many people used to do scans on 16 slice or 32 slice or even 4 slice. So it started with 4 slices maybe 20 years back, and now it has reached that CT angiography should not be done in machine which is less than 64 slice, because the sensitivity, specificity, and even the results definitely matter a lot to us, and we don't want to toggle with those results. So what do we need? A SOP like standard procedure has to be there. So we must know the creatinine, we must know the breath-hold, and different previous histories of the patient has to be taken properly. So in all, it's a demanding procedure on the part of patient, on the part of machine, as well as on the part of the different investigations prior to the study. The staff has to be well trained. A counseling for the patient has to be well done, and the consultant has to be present on the machine or the on console before doing study, because there may be few variables which a consultant only has to manage. So in demanding procedures, so we need a patient preparation. What patient preparation has to be done? One, we have to take prior history of bronchial asthma, diabetes. Then we have to take history of significant allergic reactions. We have to check for his heart sounds, BP, whether the heart rate is proper or not. Serum creatinine is important because we will be injecting iodinated contrast to these patients. Prior ECG is important to show whether there were any ectopic peaks in those ECGs. So we have to manipulate our scan in a manner that we will not take the scan during the part of ectopic peaks which is going on. Patient weight needs to be known, because depending on the weight, we will be injecting the contrast. And operation previous history for CABG or bypass surgeries or grafts has to be taken from the patient, and the contrast reaction for severe drug reactions or allergies has to be taken because of its importance because patient may be reactive to the contrast which we will be injecting if he is having some allergic reactions to the other contrast media or other drugs. Usually, people ask to withhold water or food intake to this patient, but water intake has to be continuously given or should be continued for all the patients because we don't want patient to be dehydrated. We want a hydrated patient because we don't want to injure the kidneys. So, best thing is to ask patient to drink water throughout the preparation time, which is 24 hours to 48 hours prior to the study. And we don't ask patient to be nil by mouth. They can have some breakfast, and after say 1 hour 2 hours after the breakfast we can take the patient in for the scan. One of the most important aspect is the heart rate stabilization. Heart rate stabilization is really important because we need to give the patients multiple medications, and those medications are really important to stabilize the heart rate of the patient. And this has to be done maybe a day prior to the study or on the day of study and just before the study. So what we usually do, we give some medications like beta blockers or ivabradine to these patients. Even IV beta blockers can be used to stabilize the heart rate. What usually we do is to give oral tablets of ivabradine, maybe 5 milligram of ivabradine, one or two tablets together, wait for half an hour to an hour, then look for the heart rate reduction. If the heart rate has reduced to the desired level, we will take the patient in for a scan, or if it has not, then we may repeat the dose, or we may give a combination of ivabradine as well as beta blocker to this patient so that we can reduce the heart rate to a desired rate. So what do you mean by heart rate in a desired range? So heart rate in a desired range, I'm just trying to take out this box from here. So yeah, so the heart rate in a desired range has to be below 60 beats per minute. Anything below 65 is really going to give us good results. But if the heart rate is more than 70, machine and hardware software will be tested a lot to get good images. Usually we have different manuals where we can still get good images with a heart rate of 70 or above. So whenever we are talking about these drugs to reduce the heart rate, we have to know their side effects, their contraindications, and if at all something bad happens to this patient, the treatment which has to be given to these patients. So beta blocker, as we all know, is a antihypertensive, but it does cause something else in the vessels. So it can activate bronchial asthma if bronchial asthma is active in these patients. In cases of severe aortic stenosis, we cannot give beta blockers. In cases of patient with already on verapamil, we cannot add beta blockers. And if the patient is having second or third degree heart block, we cannot give beta blockers to these patients because they may land up into severe hypotension, bradycardia, bronchospasm. Treatment is definitely known to all of us that atropine, glucagon, dexa, or bronchodilators can be given to these patients to make the patient stable again. For ivabradine, there are no significant contraindications, but very low BP or heart rate can be one contraindication. So definitely we need ivabradine to reduce the heart rate, and the heart rate, if it is very low, we need not to give any medications for that patient, as we need a good desirable heart rate without giving any medications. Nitroglycerin, which can be given to these patients or maybe given to the patient to mildly dilate the coronaries, is significantly contraindicated in patients where sildenafil or Viagra is given, because it may land a patient with severe hypotension, and it may be really impossible many a times to just recapitulate that patient or just resuscitate that patient because of severe hypotension because of the reaction of nitroglycerin and the sildenafil or Viagra drug causing severe hypotension. So this has to be taken into consideration. A proper history with all the medications, especially Viagra, sildenafil related drugs, or bronchial asthma has to be taken before the patient. So another important thing is the breath hold instructions. So we have reduced our heart rate. So there are multiple videos which we can show to the patient how to withhold the breath. We have to take the same breath hold every time. Why it is important? Because we are reducing the heart rate to get good images. Now, this is one example. If you are in an African safari and trying to capture a cheetah with a very good camera in your hand, If the camera is of low quality, definitely there will be blur in the image. If the camera is of very good quality, heart rate is wonderful, below 60, you're going to get a crisp picture. But if at all during that period patient leaves his breath, then what is going to happen, that we will be completely missing the cheetah, or we will be completely missing the structure of interest, and we will be getting something else. So here you can just see face of the cheetah and no rest of the body of the cheetah seen in the photo. So we don't want patient to leave his breath and capture something else with other than the desired. We put large cannulas, we put ECG leads, and then we do scanning. For coronary arteries, we don't involve complete chest. So most of the part of the lungs is not involved during evaluation of coronary arteries or doing cardiac CT. So rest of the part of the heart as well as lungs are involved. So many times people ask us that give me some idea about the chest. There was some infection in the upper lobe, but I'm sorry, because it's an ECG gated study, I have to limit my study to the desired part, which is from the level of carina to the base of the heart. So only scanning will be done in this part. There are exceptions where CABG, which we will discuss at the end of this talk. Then we do calcium score. Calcium score will give us idea about how much calcium is deposited in the coronary arteries of the patient, and that will give us indication about the severity of the coronary artery disease. Lesser the calcium, lesser will be a severity, but a caveat is that calcium will give us idea about the calcified plaque, but it is not going to give us any idea about the soft plaques or the fatty plaques. So it is not a great marker for the soft plaques. But yes, some calcium in the vessel is going to give us idea that there is start of coronary artery disease in this patient. Severe calcium, definitely there is more probability of that patient having coronary artery disease than a patient not having any calcium in the coronaries. We inject contrast according to the weight and see the duration of the scan. We start the scan by keeping some HU values, and when the contrast reaches aorta, we start the scan. We have different type of reconstruction to reduce the radiation dose to these patients. And then when we take a scan, we look at the images, and there are few criteria where to see that we have taken a good scan or not. A good scan should have left ventricle having maximum contrast and right ventricle having no contrast at all, so that we can see coronary arteries nicely. This is another criteria where the density in the descending aorta has to be equal to the density in the left ventricle, and that will give us idea about a good scan without any breathing artifact. So after doing a good scan, what are we going to get? We are going to get good images, which we will reconstruct in VR forms. Like these are volume rendered images where coronaries are nicely seen. But what we evaluate are the multiplanar reconstructions of the vessels. So this is LAD throughout its extent. This is RCA throughout its extent. This is LCX, what we are evaluating. And all these images will give us a good report. What about the radiation dose? We have technology that has reduced the radiation in all the scannings in newer machine to significantly lower levels. So radiation, whatever medical radiations are nowadays given, are really insignificant and is not having much correlation with any cancer possibilities. So a diagnostic radiation does not cause any significant carcinogenesis in the patient, whether young or adult. So if at all an imaging is required, and X-ray imaging is required, we can, without any hassles, we can send those patients to do CT or X-rays, that these radiations are not going to cause any harm except in pregnant ladies. So definitely for all the pregnant ladies, we do not give X-rays in first or second trimester. But the dictum is that for pregnancy, we usually avoid X-rays. But for rest of the imaging, there is no contraindication for the dose of radiation as a unit. So KB selections also definitely helps us to reduce the radiation doses. And this is how the imaging starts. So these are the ECGs. We see that there is a uniform ECG waveform, and then we start and look at the ECG pattern after the study. So these are the areas where my images were reconstructed in the RR interval. So all the cardiac scans are ECG gated scans. So we capture ECG, simultaneously we capture images, and those images are captured in a form where heart is more stable, that is the diastolic images. We can capture images in the systolic phase of the heart contraction, and there we will be getting different part of the images. So if I'm not going to get good images in this part, I can reconstruct images anywhere from 0 to 100% of the RR interval. So these are the different phases I can reconstruct. So if I'm not getting good image in 75% of the RR interval, I can reconstruct a 0% RR interval, 20% RR interval, or 30% RR interval. So that in a single reconstruction phase of the image, if I'm not getting good image, I can reconstruct other image and see other vessel, which vessel was not nicely seen in the previously reconstructed images. So I have some mobility after acquiring images also. There are few good softwares now available. So look at this step artifact, which may be interpreted as a stenosis. So if we look at the intelligent border recognition software, we apply that, and this artifact is absolutely gone. So these softwares can recognize borders of the vessels and can align those borders nicely with one another to reduce the step artifacts which can be present in many of the patients. There are different angles where we look at the images, not in a single plane. We look at the images in multiple planes, in flat panel, in multiplanar reconstruction, and we evaluate images after looking at all the reconstruction parts. This is one of the example where we look at the image. So this is the vessel. You can see the cursor moving around, and I can see that cross-sectional part of my image here in this part. If at all it is stenosis, I can look at the stenosis. This is one example where stenosis is seen, but once I see the image in a straight form, I can see that the image is the vessel is curved and then going ahead. And the image which I'm looking at here is actually taken at this part where actually the vessel is coming from the proximal part of the vessel. So there is no stenosis. Only thing is vessel is originating from proximal where I am looking at right now. And this will give me good evaluation of the vessel, which is not stenosed at all. Now, what other pathologies I can look at? I can look at the root of the aortic anatomy completely for the root, where I can look at the sinus of Valsalva, I can look at the sinotubular junction, I can evaluate those structures, I can look at those valves, and this is very helpful in cases of the TAVR, like transarterial aortic valve replacement, which is now very predominantly done in patients with aortic stenosis. For this, aortic root anatomy evaluation is really important, and that is going to detect the size of the implant which has to be put in the patients. So this is going to give me idea about my aortic root evaluation. I can look at my sinuses of Valsalva, where coronaries are arising. Is there any pathology? Is there any calcification in these arterial origins as well as in the proximal disease? All the things can be nicely evaluated during the CT coronary angiography. Coming back to the coronary artery anatomy, once the coronary artery anatomy is looked at, we can see multiple images of the coronary arteries, and this is the origin of left main artery, this is the LAD, this is LCX, and we can see that these vessels are nicely seen on the volume rendered images. We can see even the branches of the vessels which are coming out from LAD as well as LCX. Now this is the RCA. So right coronary artery is between the right atrioventricular groove, and this is the large PDA branch which is coming in the posterior interventricular groove. If you look at the previous images, this is left main artery, this is LAD, this is D1 and the two branches. The LAD always lies between anterior interventricular groove. So this is the right ventricle, this is left ventricle, and the LAD is lying between the groove in between the two ventricles, which is anterior interventricular groove. LCX will be in the left atrioventricular groove, RCA will be in the right atrioventricular groove, and PDA will be in the posterior interventricular groove. So we can look at the anatomy nicely. We can, by location, we can identify the vessels, we can see its origin, and we can detect some anomalies in the vessel origin. We cannot only just concentrate on the arteries, but we can see the veins, we can see pulmonary veins as well as the SVC and IVC and see their anomalies if present. So this is one of the anomalies or variants we can call, where the RCA which is has to origin from the coronary cuspia or the sinus of Valsalva is originating again cranial to that of the sinus of Valsalva, which we call as high takeoff of RCA. Similarly, the left main can also take off from the part which is cranial to its normal origin, and that is called as high takeoff of left main coronary artery. There can be some congenital anomalies where coronary cameral fistula can be formed, where a coronary artery going directly can again go and join one of the right-sided chambers or any other chamber of the heart, which is called as coronary cameral fistula, that there is an aberrant communication between coronary arteries and one of the heart chambers, when it can be a cause of left to right shunt. And this is one of the example where the coronary artery is directly opening into a right atrium, and this is a left to right shunt. Then there are anomalies of origins of coronary arteries, where something which is called as malignant coronary artery anomalies. So we have heard many a times that a marathoner who is doing wonderful marathons, maybe one or two or three marathons, and suddenly he has chest pain during the marathon, and there is a sudden death of that patient because of heart attack. So many a times these are the causes of heart attacks in cases of marathon runners. And what are these? These are called as malignant coronary origins. So if a right coronary artery is arising from left coronary cusp, then this coronary artery has to pass between aorta on one side and the pulmonary artery on the other side. So when you are running fast, your heart rate increases, the aorta dilates, the pulmonary dilates, and now these dilated vessels is causing compression of the artery which is passing between it, giving rise to myocardial infarct in the supplied territory. So this is one of the major causes of myocardial infarcts in apparently normal athletes or apparently normal human beings without having any predisposing causes and having sudden heart attacks. So this is one of the causes of that and has to be evaluated in patients having mild chest pain. So this is one cause. Even the left coronary artery can arise from the right coronary cusp and then passing in between the pulmonary and aorta, causing left-sided malignant coronary anomaly. Now coming to the vessel disease can be calcified, vessel disease can be fibrotic, vessel disease can be a soft plaque and causing calcifications and areas of narrowing. We can see the vessel disease in multiplanar reconstructions, in volume rendered images, or in a globe or different formats of imaging representations. So this is one of the example where circumflex is nicely seen, left main is nicely seen, but we can see that LAD is having significant calcification, LAD is having ostial narrowing, and we can see there is partially calcified and soft plaques, with both seen causing severe narrowing in one of the vessels. So there is now concept of vulnerable plaque. Madhav Bag has taken a lead in this and has done wonderful work. We have presented few papers also regarding the vulnerable plaque anatomy as well as treatment about that. One of the recently published paper was in 2023, where I was also one of the co-author in that, where a vulnerable plaque is that a plaque which has propensity to rupture. So most of the myocardial infarcts which we have seen, 50% of the myocardial infarcts are because of plaque rupture rather than the stenosis. So if the patient has gone for catheter angiography and there is no significant stenosis, and still the patient has myocardial infarcts in maybe at 1 month or 2 months after that, then there is a chance that patient had vulnerable plaque, which is not causing significant luminal narrowing in the coronaries, and it has ruptured into the vessel, causing distal vessel occlusion. So what are the characteristics of vulnerable plaque? These characters are only seen on CT coronary angiography. What are those? This is a plaque having significant lipid-laden center, which is giving us a napkin ring appearance. The plaque is surrounding the vessels completely. A long segment of plaque having significant hypodense fatty area. Then there is significant narrowing in the region of the plaque. So one is remodeling, second is spotty calcification, third is napkin ring appearance, and severe stenosis. So these are the characters of vulnerable plaque. So this is one of the example where vessels are absolutely normal on catheter angiography. Only mild vessel disease was reported. But if you look at the CT, there is a big surrounding soft plaque and inflammatory changes around the vessel. The center of these plaques are having very hypodense areas, which are representative of fat within the plaque. And after doing this CT coronary angiography, we advise the patient to be to go to his cardiologist or diabetologist as well as a physician to start on statins or plaque stabilizing agents. They did take cognizance of our report. They started him on the plaque stabilizing agent, and within 1 month of starting stabilizing, patient had MI. The plaque burden was so much that without having stenosis, still patient had MI because of rupture of one of the plaques. Patient was knowing the history. He had CT as well as catheter angio previously done, so immediately went into hospital and can be saved within the time, because he was knowing that it could be a MI, and he went immediately to patient to the clinic. So these are the wonderful things what CT can detect. CT can detect the stenosis nicely. It can predict the stenosis when there is no calcification. If there is calcification, then definitely there will be some differences in the percentage calculation of narrowing, and that has to be taken care. Then CT can detect the plaque character, whether it's a soft plaque, fibrous plaque, and we can even quantify what plaque and how much is the quantity of plaque present in that vessel. So this is one of the example where we are looking at the LED. Throughout the extent LED is diseased, we have given color codes to different plaques, and we can tabulate it in different manners. So a plaque which is less than 30 ounce unit is a fatty plaque. Plaque between 30 to 130 is a fibrofatty plaque, and a plaque which is more from 130 to 350 will be fibrous plaque, and a plaque which is more than 350 will be the calcified plaque. So we can characterize, we can quantify those plaques and give it for the further follows. Now, if you have standard, like what quantity or quality of plaques this patient is having in his previous study, and we give him treatment, we can follow him up after 6 months or a year, and we can see that there are changes in the plaque characterization of these vessels, where the soft plaques which were initially seen may convert into fibrous plaque. The fibrous plaques which were initially seen will be converted into calcified plaques. So we want that plaque to get calcified as early as possible so that it will not rupture. So a stable plaque will be a calcified plaque, a soft plaque will be a vulnerable plaque. And we don't want vulnerable plaques to be present in any of the coronary arteries. What we want is a calcified plaque present in a coronary artery which will not rupture and which will not give embolization in the distal vessel. So we can characterize those plaques. We can see it in a follow-up study that there are changes in the plaque characters of the involved vessel, and we can tabulate it and give direct information to the patient as well as to the clinicians. In addition to that, the coronary angio also gives us idea about the structure of the heart muscles. It can give idea about any abnormality, like in this case, there is a rupture of the myocardium post myocardial infarct and giving rise to a large pseudoaneurysm. We can characterize, we can give information about the neck of the aneurysm so that this aneurysm can be treated surgically. We can look at the vessels with stents. We can look through the stent properly, and we can evaluate the stents nicely. How many stents are placed, in which vessel stents are placed. We can even see the lumen of the stent. We can see the density, whether there is any proximal disease to the stent, distal disease to the stent, and how the densities are there. We can see the fractures in the stents. Yes, stent can also fracture like a bone because of the high movement along the stent or the curvature of the vessel, and we can look at those stent fractures. We can look at the edges of the fracture, and we can see whether there is any extravasation or not and characterize it. So this is one of the case of pseudoaneurysm, in a case where fracture stent, complete fracture of the stent is seen, giving rise to a large pseudoaneurysm. CT can also help in looking at the displaced or malpositioned stent. This is a left main stent, which is part of the stent is still in the aorta, ascending aorta. We can evaluate those parts. We can give information about the stent's misplacement or malposition to the concerned surgeon or cardiologist or treating physician. Not only that, nowadays, because of number of stents has increased significantly, we are bound to see some infections related to stents. So CT can see those infections nicely. CT can see which stent is involved. So three stents were put in this patient and only one stent in the RCA was showing infection around it. And it is showing pericarditis-like signs. And CT can see that there is granulation tissue along the RCA stent. And it can give information about the stent. Whether the patient has to be taken for conservative management or surgical management has to be decided on patient's condition, and we can follow up those scans and follow up those patients and see whether there is any improvement in the infection process or there is any regression in that. So we can see whether there is any progression in the vessel disease after the stent. Now, in this case, the stent was placed in proximal LED, and we can see there is progression of the disease in the LED distal to the stent part. We can see the narrowing of the vessels. We can see reduction in the opacification of the vessels, and even we can see multiple collaterals which are supplying the distal LED, which are coming from LED. So we can evaluate the vessel, we can see the stent, we can see the disease progression distal to the stent, and what we can see is a collateral vessels which are supplying that part of the LED, giving rise to good opacification of distal LED, distal to the narrowed or the obstructed LED. Now, there can be some protocol variations which are required if you want to evaluate post-CABG patients. Because in CABG, what they do is REMA and DEMA are taken out from its normal part. So origins are maintained and distal REMA and LEMA will be taken out and will be grafted to the native vessels like LAD, L6 or RCA of the heart. So we can evaluate those vessels. So for evaluating those, we have to go cranial. So usual CT coronary angiography will be restricted to the carina. But for evaluation of CABG, we have to go cranial up to the root of neck and then start the evaluation from root of neck to the base of heart. This is going to give us idea about the graft vessels. In this case, this is a REMA graft which is taken. We can see the anastomotic sites. We can see vessels distal to the anastomotic site, whether they are opacified nicely. This is a LEMA graft. We can see the LEMA graft proper showing proper opacification. There is no narrowing anywhere, and we can see LED distal to the anastomotic site nicely and can evaluate those vessels also. So this is another example of LEMA. This is the anastomotic side and distal LED. This is another example of an SVG graft, which is from the aorta to the distal AM and vessel distal to the anastomotic site is nicely visualized. So this is an SVG graft which was obstructed initially, and then one stent was placed in the SVG graft, and now it is opacifying nicely with some vessel disease still remaining distal to the graft. So all these informations can be nicely given with CT coronary angiography. So we can look at the graft obstruction. So this is one of the examples where the graft is obstructed and we cannot see anything distal to the anastomotic site. So this is LEMA graft. This is LEMA 2 RC-Y graft was taken, REMA Y graft, and this Y graft is absolutely obstructed now. We cannot see any opacification in that vessel, but still we can see good opacification of the grafted vessels, which may be because of the competitive flow coming from a normally flowing artery. So this is one of the example of competitive flow where graft is occluded and the ramus is nicely opacified from the stent which is placed, and that's why the graft has occluded, because the normal flow from the vessel is restored and there is no need for any additional graft for this vessel. So these are a few examples where competitive flow can take over the graft vessel and show normal opacification. Simultaneously, whenever there are operations, there are complications. So we can evaluate the complications post CABG or post stent, like post stent, what we have seen, like infection. Similar ways on site infection along the sternum are nicely seen on post contrast CTs or the follow-up CABG protocols. We can even see the dissection which is present in ascending aorta post CABG. There could be some aneurysms post CABG, and there could be big area of inflammation and infection along the sternum in the pre as well as retrosternal region, and all that information can be given to the treating surgeon who can debride or treat those patients to save the CABG grafts. there is something which is called as triple rule out. So not only coronaries, I can look at the coronaries, pulmonaries, and aorta in a single code. And that is going to give me something which is called as triple rule out. So triple rule out is a study where in a single study, I can give information about all the three vessels. Am I audible, or is there any issue? Because I can see some students or someone scribing something.
You're audible, sir.
Sure. Thank you. So this triple rule out will give us information about one, coronary pathologies, second, pulmonary embolism, and third, aortic dissection. Because many a times the chest pain or a back pain can be so confusing that the clinician may get confused whether this is myocardial infarct or this is aneurysm or this is embolism or dissection. So for that evaluation, we have something called a triple rule out. We modify our contrast injection a bit. We modify our acquisition parameters a bit. And what we see is now, what we discussed initially, that whenever we are looking at a good scan, we think about that the LV is nicely opacified and RV is not. In this scan, we can see pulmonary, we can see aorta, we can see RV, we can see LV, and we can see coronaries. So this is one of the example of triple rule out where pulmonary embolism was noticed. This is another example of a triple rule out where we wanted to evaluate coronary arteries as well as aorta, and a big aortic type A dissection is detected. Pulmonaries are nicely opacified. Pulmonary veins are nicely seen, but the dissection of aorta is nicely seen too. And this was a cause of his chest pain. So this is a big dissection which is seen on the VR images. Origins of RC and left main arteries are nicely seen and not having any issue with that. So now during the era of COVID, we have evaluated with triple rule out, we can add like evaluation of the chest to give us idea about the viral pneumonia. So the future comes with the CT angiography showing FFR, that is fractional flow reserve of coronary arteries, can be detected on a normal CT angiography which is done. Definitely we have to send this data to a core lab, and then the core lab will give us idea about the fractional flow reserves of particular vessels by the computation of the images, and it will give us idea that which vessel is showing normal fractional flow reserve or reduced fractional flow reserve, which is important in cases of the marginally diseased vessels. So if I give you something like my coronary artery is 50 to 60% narrow, patient is having mild chest pain. Now the chest pain is because of the partially obstructed coronary or something else. So what we need, whether the flow pattern is nice or not, that has to be detected by something. Right now we have a tool, like cardiologists have a tool where they can put the catheter in and do catheter FFR, fractional flow reserve. But if we can do it without putting a catheter in the heart, then that will be a wonderful idea. And that's what CTFFR does. It can calculate the fractional flow reserve without putting any catheter inside the coronary arteries. And that is going to give us wonderful ideas about whether this plaque or diseased vessel has to be treated or not. And this is the wonderful idea of CTFFR. Maybe a year or two, this procedure will be available to all of us in recent future. So if we talk about gold standards, whether CT coronary angiography is a gold standard or catheter angiography is a gold standard, I can just put a table and then we all can decide. Vessel lumen evaluation, both CT and catheter angiography does vessel lumen evaluation nicely. Catheter angiography does it better than CT because it can see only lumen and nothing else. But if you look at the plaque characterization, then catheter angiography does not give you much idea about the characterization of the plaque, except few thickly calcified plaque. It cannot identify the rest of the plaques. But CT will give us idea about the plaque characterization, whether it's a soft plaque, whether it's a hard plaque, calcified plaque. All that evaluation can be nicely given by CT angiography. And it is really important for those 50% of the patient where there is no significant damage. So in cases where there is no narrowing and patient is having vulnerable plaque, CT is going to score much over catheter angiography. For rest of the cardiac structures, CT is going to be the gold standard because we will be giving all the structures in a single acquisition. Flow analysis, presently Catheter angiography can do FFR, CT cannot do FFR. Complications of local and contrast are equal in both because same contrast are used for catheter angiography as well as for CT angiography. We definitely need better breath holds of the patient, and if the patient is very sick and cannot hold his breath, CT angiography is not at all the modality. We should go ahead for catheter angiography. So there are multiple studies, and one of the important studies is a NICE guideline which UK has given in 2017. It was published, and it says for any chest pain, CT angiography is the first line test. So in NHS now, if you come with a chest pain and they see there is some abnormality or the genuine chest pain is present in this patient, they will put you forward for CT angiography first, and then will decide whether to go ahead with cardiology evaluation or whether to go ahead with symptomatic treatment. So if you look at the indications, then CT coronary angiography is a class 1 indication for intermediate risk group patients for acute chest pain and no known coronary artery disease. So if there is no known coronary artery disease in this patient and the patient is having chest pain, then CT coronary angiography is a class 1 indication. For post-CBG patient pain with acute chest pain, having chest pain, this is still the class 1 indication. It is a class 2 indication for intermediate risk patient with acute chest pain having known non-obstructive disease. So artery disease is known, but it was non-obstructive initially. So this is a class 2 indication, not the first line in investigation. And for looking at the pericardium, for looking at the stress test, this is a class 2A indication. So we just have a look at the pyramid of patients where CT angiography can really make difference. So for a symptomatic patient, there is no need for any angiography. Just if you want to do a screening, then still there has to be something to do the screening. Like you have history of hyperlipidemia in family, diabetes, high stress in your life. Those history can contribute and can make you to intermediate or low risk group of patients. For anatomical evaluation, we can do CT angiography in these patients, but otherwise functional evaluation can be done with stress test. And for cardiac MR and breast catheter angiography are reserved for high-risk patients or ACS patients. So recent guidelines in 2021 has given that if you have done a CT angiography and initial CT angiography shows no stenosis, no plaque, how much is the warranty period for that? So now it has reduced to only 2 years. So if you don't have any stenosis, any plaque in the angiography on CT, then it is valid for 2 years. And if you have same lifestyle for 2 years, they don't predict that there will be any increase in the plaque. But if you have different lifestyles or lifestyle has changed significantly, then you may again go for CT angiography. And similar for test angiography, the validity is only, or the warranty period is only for 1 year. So in nutshell, we have seen what CT angiography can give, what we can detect, and what we can see while doing CT coronary angiography, how it is done, and how beneficial CT angiography is for screening of intermediate risk patients, not high risk patients, not low risk patients. Thank you.
Thank you so much, Dr. Nilay sir. Participant, if you have any questions, please put it in the chat box, or you can ask. Meanwhile, I would like to invite the president of RVPGA, respected Dr. Subhash Wage sir, to share his views.
Today is the era of of using less and less invasive techniques of diagnosis, and in accordance to that, when we are going through the today's topic of CT angiography, vis-a-vis conventional angiography, I think Dr. Nilay Nimbarkar sir has given the beautiful presentation, an excellent, very informative presentation of the subject, and whatever the anxieties the medical peoples are having regarding the CT angiography, its limitations or its hazardous effect. I think most of them are answered now, and we are more wiser in dealing with the CT angiography than before. Thank you very much, sir. Nilesh sir, being very busy person, and despite his busiest schedule, he has spared some time for us. I'm very, as a president of RVPG organization, I'm really very much thankful to you, sir. And hopefully in future also, whenever we call you, you will spare time for us with a kind heart. Thank you very much, sir, for indeed for your excellent presentation of the subject. Thank you very much.
Thank you, Adi.
Thank you, sir. So far, there is no any query in the chat box. So I know this is a quite detailed subject, being a Ayurvedic teacher or a practitioner. So it's time to conclude the session. So, as we know, the coronary artery diseases and other cardiac diseases are the part of people's life nowadays, just like diabetes, obesity, hypertension, hypothyroidism, like that. And the prevalence of these diseases are increasing day by day continuously since few decades. So, as said in Charak Sahita, Rogam Ado Parikshet Tato Anantaram Aushadam. It means before giving any kind of treatment to the patient, the Vaidyas or doctors should identify the actual illness in patient's body, and only the perfect diagnosis can lead to the successful treatment. And for that, with the detailed clinical history, different diagnostic tools like CT scan, MRI, sonography, X-ray, they help us in proper diagnosis. So, Dr. Nilay Nimbarkar sir has given a very thoughtful and provoking presentation. So huge thanks to Dr. Nilay sir. Thank you so much. This was really a valuable experience for all of us, for sure. I would also like to thank our organizer technical team for their generous support. And finally, thank you so much all the participants for attending the whole series so far now. We hope that you all have found this whole webinar series on CT scan diagnosis informative and engaging. We look forward to see you all in our upcoming next event, and we uh, we request you all to register for our upcoming national conference on Diagnocon 2025, which is on MRI diagnosis on 14th September 2025. So thank you so much once again. Thank you one and all. Thank you.
Good morning. I'm sorry, ma'am. I was delivering a lecture. I could not take your call.